Hello, how are you? Could I have your attention, please? I'm Brian Bakery. I'm the chair of the 3-minute thesis section. Proud of this. Thank you for inviting me. Thank you for inviting me. I'll remember that. Um, I'm a philosopher of science. I'm not the only one here, so I'm not a fish out of water. My primary appointment is with the Institute for History and Philosophy of Science and Technology. My secondary appointment is at the Institute for Health Policy Management and Evaluation. So I've been institutionalized a number of times in my career. The speakers you will hear from today come from our second cohort of graduate studentship awardees. Each of them are outstanding trainees working on research projects relevant to the goals of the Institute for Pandemic. They are co-supervised by IfP members from different disciplines to foster interdisciplinary learning. Each of the presenters were instructed to prepare a single slide and will only have 3 minutes to describe their project pieces. IfP staff will show them a 30-second warning sign, and then we'll ring a bell when 3 minutes are up, and it should be winding up at that point. And the presentation to end when Ted rings the bell. So I hope they've worked hard on their time, and I'm sure they have. So our first presenter, and apologies in advance if I have mispronounced any names here. Juliette Savoy, PhD candidate, Faculty of Medicine, co-supervised by Samira Muraka from Medicine and Nicole Midio from Ecology and Evolutionary Biology.
So when you go to get your flu shot, you're often in a pharmacy or a vaccine clinic in line next to other people also waiting for their shot. And you're probably assuming that what's in your vaccine is going to be identical to what's in the vaccine of the person in line in front of you and the person behind you. However, I hypothesized that this might not be the case. Influenza vaccines primarily target the hemagglutinin surface antigen, as shown in this slide. And we get a new flu vaccine every year due to the rapid evolution of the. However, this evolution doesn't just happen when these viruses are circulating. These viruses can also acquire genetic mutations when they're being propagated for vaccine. When these mutations occur, they can affect the immune response that we produce in response to vaccination. While on the surface, this may seem detrimental, a previous model developed by our group showed that having diverse vaccines may lead to better population immunity overall, because they don't allow the virus as much room to evolve when they're circulating in an immunized population each place. The goal of my project is to compare the evolution of influenza viruses in 2 different propagation methods used for vaccine production: embryonated chicken egg and mammalian cell culture. I used WHO recommended vaccine seed strains from previous years to be as representative as possible of real-world vaccine production. After growing these viruses in both methods and using next-generation sequencing to compare their viral diversity, I found that H1N1 viruses propagated in embryonated chicken eggs acquire much more genetic diversity than those propagated in mammalian cell culture. We would therefore expect egg-based vaccines to be more diverse than their cell-based counterparts. I'm currently working on reproducing this study with an H5N1 candidate vaccine virus to observe whether we see the same trend occur with propagation for vaccines against highly pathogenic avian, or to observe whether this virus's previous adaptation to avian hosts rather than mammalian hosts leads to a different trend. I hope that the results from my study will help inform best practices by vaccine manufacturers to help ensure that the vaccine that's injected into your arm and the arms of those in line with you at the pharmacy is keeping everyone protected as effectively as possible. Thank you.
Thank you, Juliet. Our next presenter is Olivia Mandolin. Olivia is a PhD candidate, faculty work in science, co-supervised by Landon Edgar and Helen from medicine and Helen Tran.
Hi, everyone. My name is Olivia, and I'm a second-year PhD student in chemistry. So I'm going to talk to you about influenza A viruses, which are, well, we just heard they're viruses which infect the human epithelial airway and have caused 3 pandemics to date, including the most notable one in 1918, that was H1N1, which infected 1/3 of the global population. So I want to talk a little bit about avian influenza A and human influenza A and the zoonotic transmission of influenza A from avian strains to human strains, which is where a lot of influenza A comes from in the human population. So on the screen here, I put this complicated carbohydrate molecule. This is a trisaccharide. And so avian influenza A strains, when they undergo specific point mutations, it changes their binding capacity towards this trisaccharide that I put on the screen here. And this trisaccharide is found in high, in multivalent displays in our human epithelial airway. And that's the carbohydrate that human influenza strains will bind to infect us. So if we want to be able to detect human influenza A strains, what we really have to do is generate and access these trisaccharides in multivalent displays for biosensing applications. So to date, I spent a long time synthesizing this complicated structure here because the chemistry is very precise, right? And so to date, I've been able to access monomeric versions of this trisaccharide, and I've evaluated these trisaccharides in a photocatalyzed polymerization approach to essentially generate a polymer that has these trisaccharides in a very dense display coming off of a backbone. So because I'm co-supervised, I'm in Professor Helen Tran's lab. She works in organic electronics. I'm working with my colleagues to basically functionalize this polymer onto organic field effect transistors. These are electronic biosensors, which basically will allow us to detect any influenza A virus strains that are able to bind to the human epithelial airway via electronic signaling. So what's great about these electronic biosensors and these OFETs is they're made of environmentally benign materials. They are very cost effective and they reach very high sensitivity limits that we really can't access with antigen PCR testing right now. And so what this will really allow us to do from the pandemic preparedness perspective is take different influenza A strains and test them in this biosensing device to see if they have that specificity for human targets and if they've undergone that zoonotic transmission. And I'm hoping we can work with scientists and engineers and public health officials to really generate a rapid test that can be deployed to the public as well. So thank you so much. And I'd be happy to take any questions afterwards if you find me.
Thank you. Our third speaker is Priyanto Saha, a master's candidate from the Dalhousie School of Public Health, supervised by Zara Chikari and Kuwan Lee from IfP and Aya Mitani of Biostatistics.
Hello, my name is Priyanto, and I'm currently finishing up my master's thesis in biostatistics. So as a biostatistician, my research mostly focuses on developing statistical methods motivated by real-world applications in health and medicine. So today I'm here to discuss causal inference for clustered survival outcomes and the methods that we've developed for it. So you may have heard the very famous saying, correlation does not imply causation. So you may be wondering, how can we then infer causation? Or how can we tell if a treatment is effective or not? Typically, randomized controlled trials are the gold standard for identifying causal effects. However, in the absence of randomized controlled trials, when they're infeasible or impossible, we might want to rely on observational data instead. If you take a look at the causal diagram up there, the blue arrow is what we're interested in, the effect of treatment on the outcome. However, what complicates things are the confounding. So we might notice some of the arrows that, some of the common causes for both the treatment and the outcome, which are what really make things difficult for us to understand. in a randomized control trial, you wouldn't have any arrows pointing to treatment because, of course, treatment assignment is randomized. So causal inference is also more complicated with time to event outcomes. And the analysis of time to event outcomes is often called survival analysis, typically because the most common event of interest is death. However, one of the main issues in survival analysis, if you take a look at the red box over there, is that we sometimes have right censoring, which means that we only observe up until some time C. So if we don't observe the event time T, as in the top timeline up there, we might notice that, oh, we don't really know how long the patient lived. We only know, we don't know the exact time of the event. We only know that they survived up until the time C. However, in the second timeline, we might notice that we do observe the event. Typically, you only observe, or always, we only see one of these timelines up there. So the last data complication that we consider is clustered data, such as when data is coming from different hospitals as shown in the green box there. In our specific data applications, we consider observational data from patients hospitalized in one of 9 intensive care units affiliated with the University of Toronto. These ICU units have different sedation protocols, ventilation strategies, and patient populations, which are expected to influence both the treatment assignment and outcomes, and we need to adjust for these things. In particular, we'll be investigating the effect of a ventilation strategy that limits mechanical power to less than 17 joules per minute compared to usual care. Limiting exposure to high mechanical power is assumed to reduce ventilator-induced lung injury and associated mortality, which is our event of interest. In contrast, liberation from mechanical ventilation or ICU discharge is considered to be censoring. Hopefully, you can forgive me for following through some of my notes there. Unfortunately, the medical applications aren't really my area of expertise. This is why, of course, biostatisticians heavily rely on interdisciplinary collaboration with doctors and clinicians. My expertise instead relies in developing generalizable statistical methods to address common real-world problems in health or medicine. If you perhaps have a complicated question involving causal inference or survival outcomes, please feel free to reach out. Thank you.
Thank you. Our first speaker is Aranthi Sankareswaran, sorry if I mispronounced that. PhD candidate, Leslie Dan, Faculty of Pharmacy, co-supervised by Minna Tadrich from Pharmacy and Etienne Godet from Public Health.
You're rushed to the hospital with a serious, but the doctors know exactly what medication. But when they go to check pharmacy shelves, it's empty. Not just in this hospital, but in every hospital in the world. So you're left waiting, hoping, as doctors scramble to find alternative medication that may not even work as well. This isn't just a hypothetical. This is happening to patients across the world as drug shortages are becoming more and more. About 1 in 4 Canadians will experience a drug shortage within the next year. Shortages, delay treatment, worsen patient outcomes, and place a heavy burden on the overall health system. So what are we doing to prevent drug shortage? There are some policies available: stockpiling, increasing importation, and boosting production during time. But with over 1,000 medications available in Canada, the real challenge is knowing which drugs we should prioritize when we think about policy implementation. And on top of this, current research focuses solely on shortage reporting. That is when a manufacturer flags a potential supply chain. But a shortage report doesn't always mean we're going to see an actual shortage as a population. So my research focuses on determining when the reported supply chain issues translate into real-world shortages that we actually see in the population, and also determine supply chain factors that make a drug more susceptible to facing actual. To do this, we linked over 6 different data sources and ran models to track when medicines face true shortages following manufacturer report. We then determined supply chain characters that are associated with higher shortage rates. We determined that having a low number of sales, anti-infective medications, and costly drugs were most linked to facing. Using this information, we then developed a predictive model that can rank the shortage risk of all Canadian drugs. This tool is already being used by policymakers to develop a national at-risk risk map. Using this information, policymakers can identify vulnerable drugs early and apply proactive policies before the shortage begins. During the COVID-19 pandemic, drug shortages weren't just common, they were critical. We failed to secure basic medicines when we needed them the most. And even now, the threat persists. With looming tariffs that pose new pressure, we may even face the next wave of drug shortages. For my research, focuses on emergency preparedness by helping build a more resilient drug supply. Through evidence-informed tools like this, we can ensure that Canadians have reliable access to the medicines they truly need during emergencies and everyday. Thank you.
Thank you. Our fifth and final speaker is Rachel Philly, PhD candidate, chemistry faculty of medicine, supervised by James Scott of Public Health, and Allison Davis.
So Canada reported its first COVID-19 case at Sunnybrook in January 2020. And from that moment on, Canadian lives changed forever. Respirators, masks, and understanding airborne infection dominated our headlines. Speaking of headlines, if you look at the photo to the left, you can see a photo of me in the lab with CBC News anchor Andrew Chen. During the filming of an episode on CBC, my research team absolutely insisted I wear a respirator during filming to protect our national treasure, not necessarily me. For essential workers who are unable to work from home, respirators and face masks became the new norm. My current research focuses on emergency service workers, including firefighters and paramedics. During the pandemic, these frontline workers faced increased exposure to bioaerosols while performing tasks like CPR, airway management, and patient lifting. In these scenarios, a respirator is often the only line of defense against bioaerosol exposure. But for respirators to be effective, it must fit. In Ontario, respirator fit testing is legally required for workers to wear them in the workplace. The standard fit test, which you may know if you've worked in healthcare or in industry, involves a series of mild exercises, nodding your head up and down, reading out loud. During a quantitative fit test, a device counts how many particles make it inside the respirator while performing the tasks and generates a fit factor. The fewer the particles, the higher the fit factor, and the better the seal. But here's the problem. Those gentle exercises may not resemble the reality of emergency, life-saving, and patient handling tasks. Think about doing chest compressions for 2 minutes, or lifting a 165-pound or heavier person. The strain on your face and your respirator is very different than reading aloud and nodding your head up and down. My research team set out to answer this question. Do respirators still fit emergency workers during the real physical demands of their job? To test this, we developed a simulated work fit test that mimics emergency tasks, which can be seen in the center of the slide. And for the past 2 years, we tested 206 firefighters and paramedics across Ontario, and we just finished sampling this December. Preliminary results show that while 80% passed the standard fit test, only 45% of our participants passed our simulated work fit test with an N95 respirator. This is particularly troubling as N95 respirators are the most commonly used amongst healthcare workers and emergency service workers. I want you to remember 3 things from my talk. 1, emergency service workers face high risks of airborne exposure. Number 2, standard fit testing may not reflect real-world performance. And lastly, simulated work fit testing can help set better protection standards and keep our frontline workers safe for future pandemics.
Thank you very much. For all. We do have a bit of time, so we could take a few questions. Ted's going to come around with the microphone and add.
So a question about the flu testing. has that method been used for other viruses or to date, or is it a novel approach?
So actually the method of taking specific carbohydrate ligands and including them in biosensors has been tested before, but there's kind of a catch because really like the portion that the AIV is binding to is just that single monosaccharide unit. It's not really a part of that trisaccharide unit. So people have tried to take that single sugar and like incorporated it into a sensing device, but there's been research that shows that if you're not emulating the entire like carbohydrate glycan that's actually found in like natural displays in the epithelial, you're actually missing a lot of like binding opportunities to the AIV virus itself. So those techniques are actually much more limited because they don't emulate the same multivalency and kind of like assisted like stereo effects of the natural sugar that actually exists in the airway. So yeah, there's been research to support that if you capture the entire trisaccharide, like the entire character, and it's in a multivalent display, you can really improve the binding. Thank you. Hopefully that answers the question. It hasn't been explored in a lot of depth yet.
We have another question down front.
Yes, thank you. I'm just wondering for the mass spec testing, is the solution then to come up with a different design of masks, or maybe to create more versions so they fit better, like compared to what we do nowadays? Thank you.
That's a really good question. So there's a longer story to this. So I'm an engineer by training. So that was actually my first question when we looked at a lot of this data that we collected. A secondary part of the study that I'm looking at is I actually 3D scanned all of my participants' faces. And because I was an engineer working, none of the PPE that I was given ever fit me. And that put me in a lot of precarious situations. So I'm particularly interested in linking different facial biometrics to how respirators fit. And I'm hoping that will help inform the standard that traditionally NIOSH sets on how respirators fit to workers. So like incidentally, it'll like look at how new respirators are designed for the future.